Hi, and good morning, and welcome to my second lecture for you guys. This lecture is going to be about genetics and the low vision patient. So first we're going to go over why we should do genetics on low vision patients. Then we're going to talk a little bit about genetics at Bowden. Then we're going to go over some cases and some current gene therapy. So why test genetics? First of all, genetics is going to confirm a clinical diagnosis in these patients. A lot of these patients have never known the exact cause of their visual impairment, and getting these answers helps provide an accurate prognosis as each disease acts a little bit differently in terms of visual impairment, progression, and atypical presentation of this disease. Uh, most of these diseases that a lot of the diseases that we see do present atypically, and so it's not uncommon for these patients to just really not have no idea why they have a visual impairment, and they definitely appreciate having an answer. In fact, a study done by Informed DNA shows that after genetic testing, about 13% of the clinical diagnosis is changed once they knew those results. So that's about a little bit more than 1 in 10 patients. Their clinical diagnosis and their genetic diagnosis differed. Genetic testing is also going to confirm an inheritance pattern and properly assess the risk factors for other family members. Knowing exactly what genetic disease that they have will help them determine if they qualify for clinical trials or gene therapy. We'll talk a lot more about RPE65 and Luxturna, which is the only FDA-approved genetic therapy out at the moment. And currently there's over 36 inherited retinal disease clinical trials underway, but most of them are requiring a genetic diagnosis before you can even enroll in the study. So it's really kind of just the future of which patient care and low vision is definitely going in. Genetic testing at UIW, the patients that are going to qualify for this testing are patients that are going to be symptomatic for night blindness, central vision loss, peripheral vision loss, extreme photophobia, or a deterioration of their color vision. And the reason why is because the testing is sponsored from one of 2 genetic companies, and these 2 genetic companies only sponsor symptomatic patients. So the genetic companies that we work with at Bowden is Spark Therapeutics, and they work with Invite, which is the genetic, which is the company that runs the genetics, and that's all done through a program called ID or IRD, which is your inherited retinal disease. And this panel is about 250 genes, but they do not include that mitochondrial DNA. Genetic counseling services are offered over the phone. So if you did not have access to a genetic counselor in your clinic, you could have one offered to the patient over the phone. The other company that we work with is Blueprint Genetics, and they're funded through the Foundation Fighting Blindness. And their gene panel is about 322, and they do have mitochondrial DNA, but that's just a recent ad. They also have this My Retina Tracker, which is a database for both the clinician and the patient. So the clinician can go ahead and type in visual acuity, as well as ERG results, clinical diagnosis, and a little bit of family history, as can the patient. On the patient portal side of things, it also acts as kind of a support group for these patients. These patients have access to other individuals who might have had the same genetic diagnosis for these. So it really is a community on them. So why are these genetic companies sponsoring these eye exams or these genetic tests? So genetic tests are normally thousands and thousands of dollars, and what is the benefit that they do this? Well, let's not be naive to the fact that these are companies, and what they're doing is they're trying to create a database of genetic information. They want to know which inherited retinal diseases are common, which are not, where should they be sticking their research money and kind of their drug money. So right here I have labeled, they're creating a database of orphan diseases. So the orphan diseases is defined by any disease that has less of 200,000 people who are affected of it. So most inherited retinal conditions kind of fall among that. These genetic companies do not sell personal information, which was really important for us when we were deciding whether or not we wanted to work with them. Other genetic companies, any other private ones, may or may not be selling individuals' genetic information to advertisers, to insurance companies, that types of things, to law enforcement. And we wanted to be sure that our patients would be safe and secure with these companies in which they are. I don't want to be naive to the fact that Spark Therapeutics, the first company that we work with, is the owner of Luxturna, which is the only FDA-approved drug out there for that RPE65 genetic mutation. So always something to consider when you are offering like products and services to patients, kind of what does this mean big picture? So the patient experience at UIW is, first and foremost, we are eye doctors. We need these patients to be having a comprehensive eye exam. Someone needs to be taking a look inside those eyes and monitoring that disease. But once they have a comprehensive eye exam, they're going to wait 30 minutes without eating or drinking, and then they're going to provide us a saliva sample. So what they do is they just spit into this tube here, and there's a line here that they fill up, and it has a false bottom to it, so they're really only filling up about 1 inch or so of saliva in this round tube. Some fun things that the instructions say on it is that you should like think about your favorite food, or rub the inner cheek of your inner cheek with your tongue, or think about lemons, all of these things to produce some saliva so that you can produce enough spit to sit in there. Patients are kind of uncomfortable with spitting in front of you, but sometimes I'll just leave the room while they're doing that. So then once they're done spitting, what happens is this tube snaps shut. There's a fluid in this top part of the tube that runs down, and it enzymatically secures that DNA so it doesn't degrade over time. So this has a shelf life of about 4 weeks, but we do rush ship the samples to the companies so then they can do their DNA analysis on it. Then once the DNA analysis is done, it takes about 4 weeks to do the DNA analysis, and we'll get the results back, schedule the patient back, and then Dr. Schmidecki, Dr. Sanchez-Diaz, and I all sit down and talk with the patient. We encourage them to bring their families to this visit, as it can be emotionally overwhelming to these patients. So we just encourage that there are other people there for support, but also so that they can listen and ask questions as well. So Dr. Schmidecki and me, the resident, are in there more to discuss the prognosis and of the disease and what this looks like from a clinical or a functional standpoint, where Dr. Sanchez-Diaz is going to be doing the genetic counseling. Genetic counseling is a profession. They do have a master's degree in genetic counseling, and they are specially trained to advise individuals of their genetic disorder. They go over the medical side of things, the psychological side of things, as well as the familial implications of these genetic results. And I think this really just stresses the interdisciplinary nature of low vision. We're so blessed to work with Dr. Sanchez-Diaz, but anywhere where you are providing genetic results, know that you are an optometrist and you are not a genetic counselor, and making sure that you really are reaching out to the professionals who know exactly what they're doing. I have a picture of Kleenex up here. We've had some very emotional cases come into our eye exams for our genetic testing, and it's just really important that you are dealing with this with the delicacy that you would want to be finding out this news. Sometimes when it's parents finding out about their child's condition, they can be very upset because they're losing the thought of like having a quote unquote normal child. Even if that child, the prognosis is super good, it can just be extremely overwhelming, and we just need to be aware of that. Low vision is all about emotions and, really getting personal with your patient, and just making sure that you always have that in the back of your mind. So the results that you can kind of get from a genetic standpoint is going to be kind of one of three. So we have, first of all, the pathogenic. So this is going to confirm a clinical diagnosis, and it's also going to kind of tell you, with some sort of confidence, kind of like what the prognosis of this and how we go about it treat this. A negative test result I've seen, it confirms that there's no underlying genetic component to it, but there is probably going to be underlying pathology. One example I have is one individual had some things going on in her retina that were a little bit abnormal, but they thought that it was like this uveitic explanation, but we just did the genetic testing to confirm. And what it did is the results were negative, saying that it is this uveitic nature, and that we should continue to treat them with the medications that we know. A negative test is also going to lessen the familial risk of this being passed on. So just as important as a pathogenic result, a negative result can be just as important. The more exciting part about all of this genetic testing are these variants of unknown significance. So that's kind of broken down into two different categories here. We have the likely pathogenic, which has been labeled as a protein that we know that this genetic mutation causes a protein misfunction and is likely to cause a disease. However, there's not that much clinical science behind it. Versus a variant of uncertain significance, there just is not enough clinical data out there to know whether or not it is going to cause a genetic mutation. And that's kind of where the really fun part about the genetic therapy or the genetic testing is right now. So let's go over a few cases. So the first case I want to talk about is a 58-year-old African-American woman presenting for a low vision exam and genetic testing. She's had a clinical diagnosis since the age of 9, and the doctors have told her that she'd never see 20/20. Her visual acuity is 2200 in the right eye and 2150 in the left. Pinhole, no improvement. Anterior slit lamp exam is within normal limits. Her optic nerve heads are a little bit larger, somewhat pale, and they're 0.7 horizontal and vertical. But her macula, she has this pigmented scar over the macula with areas of hypopigmentation surrounding and a loss of foveal light reflex. She also has this pisciform flecking in her posterior pole. And here is a picture of her posterior pole. Again, we can see that pigmented scar with those areas of hypopigmentation, and you can see the pisciform flecking. And take note of the CD ratios as well. And then I think this is a beautiful picture of the FAF. So, any guesses to what you guys think it is? All right. Well, the patient is heterozygous for 4 variants of ABCA4. And if you don't know, ABCA4 is Stargardt's disease. It's the most common mutation in Stargardt's disease. So you guys were accurate if you did that. So she has, like I mentioned before, 4 variants, 1 being pathogenic, 1 being likely pathogenic, and then 2 of these variants of uncertain significance. So to dive into the genetic results a little bit deeper here, the way we read this is the gene, this is the base pair that's messed up, this is the protein that's been affected, this is the consequence of the protein. So this one was a stop, like a protein, like a truncated protein, whereas this is a missense, and then that genotype, it being heterozygous, pathogenic, and then the inheritance being autosomal recessive. The phenotype is also labeled here. We have Stargardt's on each one of these genes. So this is a little bit about how the genetic test results looks from Blueprint Genetics. So, as mentioned before, ABCA4 is the most common mutation in Stargardt's disease. It is autosomal recessive, and what happens is this is our light cycle. The light hits the rhodopsin and changes it from a cisretinal to transretinal, and we have the ABCA4 protein that goes ahead and breaks down that byproduct to the transretinal. When you don't have this protein functioning, it's going to lead to accumulation of toxic retinoid compounds and eventual oxidative damage to RPE cells and eventual RPE and photoreceptor degeneration. So our patient had 4 mutations in this protein. And again, here is her photos. You can see that total loss of RPE and PR and photoreceptors in her macula area. So why did we do genetic testing on here? Well, first of all, it did confirm our clinical diagnosis, and we know that it's not anything more than Stargardt's. Now, this patient does have a history of glaucoma, and that's a different story, but it's not going to be a rod cone dystrophy. She's not going to lose her peripheral vision in the sense of that. Also, since we've labeled her genetic mutations, we can now enroll her in some clinical trials. There were some clinical trials open and available in Texas this fall. Unfortunately, they were dropped due to likely defunding, but it is something to keep an eye out on the future. So the second case I want to talk to you about, it's a 58-year-old male, and he reported that about 7 years ago, when he was about 50 years old, he started noticing a rapid decline in his vision. Even from August, we can see that his vision has decreased a lot. So his right eye has been this 10/400 with an extreme unsteady eccentric viewing, and his left eye has dropped from 10/60 in August to 10/300 in December. And you can tell that it's been a recent decrease in vision because of this incredibly unsteady EV. Once a patient has a steady EV, you can assume that that this impairment has kind of been around a little bit longer. They've taught themselves how to eccentrically view. Now, here is his retina. You can see just this very weird discoloration in the periphery with this macular involvement here and this pigmentation here. UT ophthalmology differentials were a rod cone dystrophy and or central areolar choroidal dystrophy. When we did the genetic tests, they came back kind of inconclusive, but they had all of these variants of uncertain significance identified. So what does this mean? So we had 3 autosomal dominant and 5 autosomal recessive variants of uncertain significance. The patient's symptoms were essential scotoma, contrast sensitivity loss, and color changes. And in his family history, he has 3 children, one of which is symptomatic for some central vision changes in her late 20s. These companies will sponsor familial testing, variant testing. And this is important, especially in these cases where we have these variants of uncertain significance. We don't know where on the gene some of these mutations are, and having the family being tested can help clarify some of that information. So, but the only requirement of that being that everybody has to have a comprehensive eye exam. So with this family, we have each of these 3 children have come in for a comprehensive eye exam, and they have their genetic testing on the way. So hopefully we have some answers for this family moving forward, but this is something that's definitely incredibly active. This is an active case in our clinic, but something that you guys should inquire about when you come into clinic next year. The third case I want to go over is a 58-year-old Hispanic female. She presents for electrodiagnostic testing for suspected RP evaluation. She's noticed a decrease in her peripheral vision, especially becoming difficult driving, walking around. She keeps bumping into things. She notices it in both eyes, but she's only noticed it in the last 10 years. Remember, she's in her upper 50s, so about the age of 50s when she started noticing that. That's a little atypical for RP. RP, they kind of, you expect it kind of a childhood, young adult age to start those symptoms. Her family ocular history, her mother was suspected to have RP as well, although she is no longer with us, so we cannot test her. Her anterior acuities are 20/25, and she has a moderate hyperope. Her ERG results are grossly diminished, both the multifocal ERG and the full field ERG, and they're grossly diminished in both the photopic and the scotopic system. So both her rod and her cone system are not working as they're supposed to. And her visual fields are decreased to about 12 degrees. This is her fundus evaluation. Of course, you can see this, these white fluffy lesions in the periphery, not your typical RP. You do have a little bit of hyperpigmentation here, and you don't have that waxy pallor nerve as previously described in RP, but a pretty well sparing of the macula. Same thing here. We have those funny peripheral white lesions and some hyperpigmentation as well. These are her visual fields. This is what you can see, about 12 degrees. Now, let's not forget that her chief complaint was that she felt having difficulty driving. Remember that Texas requirement for driving are 140 degrees of uninterrupted horizontal field or a visual acuity of 20/50. So she does meet the visual acuity standards, but she does not meet those visual field requirements. So this is someone that I'm going to deem unsafe or unfit for driving. So we did the genetic results, and the genetic results came back for negative for anything describing the patient's phenotype. However, in the appendix 2, she is heterozygous for this autosomal recessive, so she only has one copy of this DHX38 gene. And it is a variant of uncertain significance. Why is that? Okay, well, let's dive a little bit more into this. So this DHX38 has been suggested to be a novel gene responsible for severe early onset autosomal recessive retinitis pigmentosa. This study came out in October. And in this study, 2 families with 2 copies of the gene, so homozygous for DHX38 mutations, resulted in having RP with legal blindness and or no light perception by the age of 6 to 8 years old. Now, this does not fit our patient's demographics at all. Remember, she's 58 years old and just experiencing these symptoms. So this is something new and exciting and something to keep an eye out for. Maybe down the line, this DHX38 will have more information and more precedence in the side of retinitis pigmentosa. Moving right along, I want to talk to you a little bit about retinal gene therapy. This is all coming from an article entitled Retinal Gene Therapy by these authors. So if there's any confusion, I definitely encourage you guys to go ahead and read that article. So inherited retinal conditions normally affect the RPE and the rods and the cones and the choroidal endothelial cells that are obviously involved in the visual processing pathway, but mostly just isolated to the outer retinal complex. So this is how gene therapy is going to work. And we'll talk about a little bit more about that later. But all of these genes that are labeled in red are areas in which gene therapy research is undergoing. So all of these genes at some point, hopefully will be, fixed. There's 2 ways to do gene therapy. The first is gene supplementation, and the second is gene suppression. Gene supplementation inserts a new gene into a diseased cell via a viral vector, and the host cell will then express that gene that's normally not making the functional protein. So it will start making the functional protein. So what's happening is this cell is here, and it's existing, but it's not making a functioning protein. So what we do is we insert the functioning gene so that that cell can then express that gene normally, and that protein can be made there. And that's gene supplementation. Now, gene suppression is when the cell is making a bad gene or a toxic protein. And what we do is we go ahead and we insert a gene that would block the making of that toxic compound. So then the cell is told not to make that protein, and the protein is no longer made, and those toxic byproducts are not made in the cell. So how do viral vectors work in gene therapy? So first we have to put the DNA into a viral vector. That viral vector then carries that genetic material into the human cell in which they can make the normal gene. The reason why the eye is a really good target is because it's really effective in non-dividing cells, and the RPE is that, so that we don't create new RPE cells. So if we can get the new genetic material into the RPE cells, then we should be safe. It should work. The virus that carries the gene, we use this adeno-associated virus. One issue with the adeno-associated virus is it only can carry genes up to a certain size. So once it gets a little bit bigger than that, we have to use a different virus. There's some out there in therapy. I'm just not going to mention them today. The virus, this AAV, when once injected, it has a low pathogenicity and it does not have a really high chance of inflammation or immune response from the host. So that's why this is something that we can work. Why else does gene therapy work? Gene therapy offers ease of access to the eyes because the eyes are just sitting on kind of the front surface of the front of the head, and there's not a lot of cutting that needs to go into to get to the eye. We also have surgical ways to get into the eye that are often used in ophthalmology now. So the intravitreal injection, which is practiced every day with anti-VEGF injections, we can insert these viral vectors there. The one problem with the intravitreal injection is the interlimiting membrane won't allow these viral vectors to get to the outer retina as needed. So the way that they insert genetic therapy into the eyes for the outer, to get to the outer complex, is through the subretinal injection. A subretinal injection is a little bit more difficult to practice, and it creates this this retinal detachment for about 14 hours. However, it puts the genetic material right where it's needed in the outer retina, and there isn't a really large immune response from that viral vector. So it is a pretty safe way to insert this genetic material. The eye is also immune privileged, so there's not going to be a huge inflammatory response in the rest of the body, whereas if you did genetic testing in other organs, we don't have that benefit. We also have a built-in control group. So one eye we could treat, one eye we can't for research purposes. And the inner retina is normally spared because we really are mostly concentrating on that outer retina, the RPE, the photoreceptors, and the choroidal endothelial cells. So before I dive into some current research, I'd like to recap the differences in the clinical trials. So phase 1 is going to be the clinical trials that's the first time that the drug is introduced into humans. It is used in healthy individuals or with patients with end-stage disease, just to determine a dosaging tolerance. When it comes to retinal injections, they do use participants that are already blind, so there's no risk to existing vision. Phase 2 is after the dosing amounts are created. It's looking at the dosing ranges to determine the effectivity of the drug. There's a phase 2 and a phase 2A and 2B. The 2A is going to demonstrate the clinical effectivity, and then 2B is going to demonstrate the biological activity with minimal side effects. And this is going to be done in a large number of patients. Phase 3 is the really exciting part about clinical trials. This is where they really start looking at the clinical value against the gold standard in a multi-center trials with large patient groups. And then phase 4 is going to be after the drug has been released and on the market for a while, what happens post-market. So several years down the line, where are we at? So currently, let's look at RPE65. So RPE65 is responsible for Leber's congenital amaurosis. It's expressed in the RPE, and it results in a deficiency of the 11-cis retinal. So this is our visual cycle. Remember when we have that all transretinal ester, and then we go to the 11-cis retinal, the RPE65 protein helps us along in that visual cycle. And defects in that will lead to a buildup here. Currently, for RPE65 trials, phase 1 and 2 have been completed, and there was improvement shown and that persisted up to 3 years. And in phase 3, they injected 16 patients, and this is kind of where we get this is definitely where we get the Luxturna gene, the FDA approval from Luxturna. So it has been FDA approved for patients with biallelic RPE65 mutations. So that is the Leber's congenital amaurosis. It is an injection of the AA2 gene, intravitreal, and it is a 65 KDA protein gene. So what that means is there's 65 base pairs that are being replaced. The results, the patients were to walk through kind of a course in different illuminance levels. This is what this multi-illuminance mobility test is. And they were able to sustain the benefit for 4 years. There was not an improvement in visual acuity, but these patients were able to kind of like walk around and move around safely. The cost of this drug is over $400,000 per eye, so it definitely doesn't come without financial burden to these patients. Current research going on in RPE 65 can be looked up at clinicaltrials.gov. There's currently 17 clinical trials, and 3 of which are recruiting, and they are going through Spark Therapeutics, that company that makes Luxturna. So when you go to clinicaltrials.gov, all you have to do is you have to type in your genetic information or what you're looking for, and then there's several different ways to search. I searched through the map, so I clicked on Texas, and then these are the 3 clinical trials that are going on in Texas right now. So the myclinicaltrials.gov is super easy to use, and it's definitely something that if you're going to be doing genetic tests on your patients that you should be referring to. The next disease I want to talk to you about is the CNGA3 and CNGB3 studies. The mutations in this gene are responsible for achromatopsia, and it's autosomal recessive disease. And it's a defect in the cone receptors. So what happens is this alpha and beta subunit of the cone photoreceptor from the cyclin nucleotide gated channel is defected. This is the channel that normally shuts during the lighted condition, and since it's dysfunctioning, it leads to this achromatopsia. So this is currently there's 4 studies going on, 3 that are currently recruiting, but also just another reason why genetic testing is so important. If we can label that these genes are the ones that are affected, we can get individuals into these studies. Retinitis pigmentosa is the most common of the inherited retinal conditions. It affects 1 in 4,000 people, and there's over 60 genetic mutations known, and there's multiple genes affected in this. We know some of them, and there's multiple different inheritance values as well. Some are autosomal dominant, some are recessive, some are X-linked, and some are mitochondrial. Just to give you a cue, this is the amount of recruiting studies for retinitis pigmentosa in Texas alone. And there's not gonna be any test questions from this slide. However, I do want to draw to your attention that the inclusion criteria, almost all of these studies, just make sure that the patient that's looking to be enrolled in the study does know what type of RP they have. So that's the reason why we're doing this genetic testing, just for more answers, and so to push science along. These are some future candidates for genetic testing, as well as there's been some thought towards age-related macular degeneration. So the theory is that if we can stop the RPE from expressing that VEGF expression from a cellular level, we would not need to be able to inject them so many times with anti-VEGF therapy. There's also a theory on the non-exudative age-related macular degeneration that if we can deactivate the complement cascade, maybe we can stop the dry form of macular degeneration. And since you all know that there is no therapy for dry macular degeneration, this is really important. Unfortunately, at UIW, we don't do genetic testing for the age-related macular degeneration, although I know it's one of those things advertised in 23andMe. It hasn't been recognized as anything of that importance, as we are honing in on those inherited retinal conditions. I want to thank you guys so much for listening, and I just hope that you guys remember your exposure to genetic testing at UIW, and you're a little bit more prepared entering into clinic. And I hope you understand the ethics that go behind genetic testing, as well as why it's so important, and how to get involved in the clinical trials. All right, I hope you guys have a wonderful rest of your day and continue to be safe. Reach out to me if you guys have any questions regarding any of this material, and thank you so much.